Can you start now? Can we start now? Assalamu alaikum. I think we can start. Okay.
Walaikum assalam.
Assalamu alaikum. Walaikum assalam. Okay. In the last class, we were discussing about the venous return of the lower limb or venous system of the lower limb. And in that, we have discussed about the venous return. And I told you one factor of venous return, that is the gravity. There are actually some other factors in general. If we consider all the factors of venous return from all parts of our body, actually these are the valves, presence of the valves, the muscular contraction, and then the pulsation of the arteries, negative interthoracic pressure, and gravity. So we must remember that all these factors don't work in all the regions of the body, or trunk, or rather, these are very much particular to particular sites or organs. Say, for example, first of all, we are considering of the valves, presence of the valves. These valves are not present in the upper extremity or upper limb veins, because in that case, these valves will hinder the return of the blood from the upper limb to the heart, as gravity is always acting on, whether we are standing or sitting or lying down, gravity is actually acting on. And you can easily understand the part above the heart will get its venous return drained to the heart easily and in favor of gravity. But part of anything below the heart will have to return the blood against the gravity, right? So valves are not needed in the upper limb veins, but valves are very much important for the lower limb veins. So you can understand valves are not important for upper limb veins, but very much important for the lower limb veins. In this way, muscle contraction is also a very important factor. What happens, you see, when a skeletal muscle contracts, it shortens in length but increases in girth, width. So you can understand this is the relaxed muscle. This was the relaxed muscle, and within it was a vein, deep vein. You can see this is the posterior compartment of the leg, and this is the posterior compartment vein. And what happens, valves are for one-way direction of blood, right? Isn't it so, Talha?
Yes, sir.
Yes. It allows only blood flow through in one direction only. It's not a bidirectional flow when the valves are there. So what happens? This is a relaxed muscle and this is a contracted muscle, and you can see the length of the muscle has reduced or shortened, but at the same time it has increased in girth, that is the breadth. And what is actually limiting the external limit of these muscles width is the deep fascia of the lower limb. The fascia of the lower limb doesn't allow the muscle to be exponentially expanded. It is limiting the breadth of the muscle. So what happens? It is increasing in breadth, but it is not getting the space to increase its space. So it will compress the inner structure that can be compressed, that is the vein. And by this compression, the blood in the vein in between these and these valves are supposed to go in both the direction. Actually does so. It goes in high direction to upwards and also downwards. But as the valves closes, when the blood is trying to get back through the valves, it is closed and returns, and the only way it can go is upwards. In this way, the blood returns to the heart. That's why it is called the peripheral heart. These valvular sinuses within the deep muscles of the back of the leg are called peripheral heart or sural heart. So this is the mechanism by which venous return is aided. And so we have discussed about the contraction of the muscles, role of contraction of the muscle, and presence of the valves. Next is the pulsation of the arteries. You know, these deep veins are located along with arteries, and the pulsation of the arteries also help in venous return by pressing the veins. Right. Okay. Next is the negative interthoracic pressure. You know, we all know that when we inspire, actually what happens, all the diameters of the thoracic cavity increases, the vertical diameter, the anteroposterior diameter, transverse diameters, all the diameters of the thoracic cavity increases, and thereby it causes makes a negative intrathoracic pressure, which allows the air to come to the lungs, and expansion of the lung occurs. This is about the respiratory system, but this negative intrathoracic pressure also creates a suction effect like the vacuum pumps, and the venous blood is drained into the thorax, eventually to the heart, of course, to the right atrium. So in this way, venous return is also increased by the negative intrathoracic pressure, right? And finally, the gravity that has been already told that for the upper limbs, the gravity is actually helping venous return, and for the lower limb, veins are for gravity is acting against the venous return. So these are the factors. It comes in written question, and also in sometimes it is asked to explain with your knowledge of anatomy what happens if the valves are incompetent. I've told you already that this leads to varicose veins, right? Because these valves are not only present in the deep veins but also between the superficial to deep veins, so that blood goes only from superficial to deep. But if the deep to superficial flow is established due to the incompetency, the superficial veins will immediately swell up and become tortuous. That is called varicose vein, right? So the competency of these valves are very important. Okay. So I think with this we can conclude this part. Now let us see this picture. Before we go to the discussion of the muscles, we can actually visualize the location and the arrangement of the muscles and everything with this very nice picture from Moore's. These two are taken actually from the Moore's anatomy, and you can see a very vivid picture where you can see the location of the bones. If we come from outside to inside, then is the skin, then superficial fascia, and the deep fascia, superficial fatty layer, the fascia, then the deep fascia of the lower limb, in case it is the thigh region. Then the intermuscular septum are these ones, and this is the location of the blood vessels, and these are the sorry, this is not the thigh region, it's a tibia and fibula, so it's a leg region. Extremely sorry. So this is the tibia, and this is the lateral fibula, and these are the compartments: the anterior compartment, lateral compartment, and posterior compartment. And you can see even within these compartments are very distinctly separated from each other by a extension of the intermuscular septum, the extension of the deep fascia that is called intermuscular septum. And you know from your knowledge of superior extremity that these intermuscular septi are actually the modifications of the deep fascia. That is why I told you this is inferex. You can infer many things from superior extremity knowledge, almost the same, almost the arrangement is same, right? You can see. And within these groups, all the individual muscles are also separated by the connective tissue septi. So in this way, actually, there is a very definite arrangement of the muscles, blood vessels, and everything, so that they can work most efficiently without wastage of any energy. Say, for example, if these fibers were mixed up with other muscles, even with these other compartment muscles, there would have been more energy to we have to expend more energy to get the same result even if it was possible at all, because I think it was not possible. Even if you get your utmost effort, if they are not arranged, say for example, you want to contract the anterior compartment muscles. If they were mixed like a chunk all together, you have to separate all these anterior compartment fibers, fiber by fiber, and then you get the effect, and that is not possible. That's why nature has segmented by the intermuscular septum, the anterior compartment, the posterior compartment, and lateral compartment, and all the muscles which will act together for a common purpose are actually grouped in one compartment. The muscles which will do another function, primary function, they are grouped another in another segment. This is for the economy of the energy and efficient contraction and efficient functioning of the muscles, right? So these are the purposes of the intermuscular septum and compartmentalization. Okay, now I'm going to show you another picture, that is venous system. We have already told there are 2665. Okay, you see, we have told you already that there are two groups of venous veins. It's actually three groups: the superficial veins, the deep veins, and the
Perforating.
perforating veins. Right, very good. So these are the superficial veins, and they are two big named ones: the great saphenous vein, the small saphenous vein, and the deep veins are that I've told you: profundifemoris vein, popliteal vein, femoral vein, and then these drain into the external iliac, and then internal iliac joins to form the infravena cava on the common iliac vein. Then both the iliac vein forms the infravena cava. That's the continuation. But these are the deep veins: anteritibial vein, and then the popliteal vein, the profundifemoris vein, deep vein of the thigh. These are all the deep veins. And some veins are there which communicate with the superficial to deep, and always these blood passes from the superficial to the deep, but not from the deep to the superficial. Why? Because if these valves are failing, then the superficial, there is low pressure there, and they would be swollen and forming the varicose veins. And one more thing we want to discuss is the thrombosis, DVT. Have you heard this term, DVT? Deep vein thrombosis? Yeah, I think so. Even for, say, for example, overseas flight from Dhaka to New York, and from New York to London, actually, those foreigners actually take a tablet before they take the the flight. Why? Because it takes almost 12 hours, and then within the airplane, actually, nobody wants to work that much, and they lie in resting position. So there is chance of deep vein thrombosis. That means in these calf muscles, this is a posterior tibial vein, this is a deep vein, and if it is not moved, the blood get thrombosed, and then this lodges. Thrombosis means clotting of the blood within the blood vessels, and these lodges, and they pass to the blood vessels higher, and finally they reach the heart and blocks the coronary vessels, or it reaches the brain and blocks and causes block. So this is very dangerous one. Even a single flight from overseas flight from Dhaka to New York may cause these things, and even you can understand so how important it is. And if we prolongly, say for example, we have a long leg full plaster, that means this plaster is from the thigh region, that is from the groin region to the the foot region. So this is long leg, this is called long leg full plaster. And in that case, if we don't advise our patients to move their toes regularly, what will happen? These calf muscles will be in inactive state, and for that there will be thrombosis formation in the deep veins, and that will be dislodged and causing same problem. Another thing is that we see that when the plaster is cut, the fracture is healed, but the muscle bulk is very reduced, very much reduced, that the person can't walk even, and also the bones become brittle. So three things happening. One is deep vein thrombosis. Second thing is that the muscles are become wasted due to disuse or less use. So the muscles become wasted, and also the bones become brittle. Why? Because the bones, is a dynamic structure, and this dynamic bone structure actually changes its mineral composition according to the pressure, that is the stress. So if these bones are not in stress, then they will be losing their minerals, and these minerals will be used elsewhere in the body. In this way, the bone will be becoming brittle. So you can understand why and how much important it is to maintain the exercise within the full leg is plastered. That's why we must give our patients these advices, right? For prevention of the deep vein thrombosis, for the maintaining the bulk of the muscle and strength of the muscle, and also the integrity of the bones thereby. Okay, now let us come. I'm just touching the points so that you can understand all these very relevant things. As I have told you that this class is for the common hand idea. Now you can see how that we have discussed about the lower limb as a whole, the regions, but we haven't yet discussed the two things. One is the bone landmarks. You can understand, you'll study it. I'm not going to detail it. Say, for example, bony landmarks are there. Is the patella here? Where if we start it from here, the anterior superior spine, pubic tubercle. These are two important bony landmarks, and one soft tissue landmark is this inguinal ligament, mid-inguinal point. Next is the important bony landmark is the medial condyle of the femur, lateral condyle of the femur. Then is the medial condyle of the tibia and lateral condyle of the tibia, the patella itself, and the medial malleolus, lateral malleolus. These are the important bony landmarks of the lower limb. And you can understand why these are very important, because if there is, say, for example, replacement of the knee joint or hip joint is to be done, one has to maintain the length of the limbs equal to the unaffected one, or the one which has not been treated by the knee replacement, right? So these, how we must know how to measure the length, limb length properly, and from which point to which point these lengths are to be maintained is very important for the orthopedic surgeons. Say, for example, he has done the surgery very nicely, but there is a little shortening of the limb. What will happen? The patient will have limping gait. The surgery is nicely done, but for this little amount of shortening, maybe 1 millimeter, 2 millimeter is not factor, but if it is 1 centimeter or more, it is a very grievous thing, and the patient will suffer lifelong for that. So this is very meticulously, this has to be very meticulously done, and that's why we must know the bony landmarks very properly and very accurately, right? So these are the importances of these. In other cases, say for example in upper limb, if it is a little short, it will not bother you because you will not be able to even feel it. But when it's a matter of lower limb, even a little shortness is marked by every step. Whenever you take a step, you will feel that yes, my limb is shortened. So it is very important for the orthopedic surgeons to maintain the length of the limb when the surgery of this kind is done. Okay, so that's why we must know the limb, how to measure the limb length of the parts of the limb, that is the lower limb, very meticulously. Now come to the 2 points. One is superficial fascia, and another is deep fascia. The superficial fascia is continuous of the upper lower limb is continuous with the abdomen, anterior-abdominal wall, and the sorry, the superficial fascia as it is in the anterior-abdominal has got two layers: superficial fatty layer and deep membranous layer. Superficial fatty layer is continuous with the fatty layer. of the lower limb fascia, superficial fascia, but the deep layer is continuous and it get attached to the deep fascia of these inferior extremity or lower limb, and this is called Holden's line, which runs along the inguinal ligament from the anterosuperior spine to the pubic tubercle. Actually, from the pubic to 8 centimeter long, it's a Holden's line, where the deep fascia, the deep membranous layer of the superficial fascia of the anterior-abdominal wall gets attached to the deep fascia of the thigh. You know it, and that's why extravasation of urine doesn't come to the deep, deep once again. Hello, G. Excuse me. Extremely sorry. You can see it. You have studied it in the abdomen, so I'm not going to that. And now let us concentrate on the deep fascia of the thigh. Okay, so that is the importance of the Holden's line. You have studied it in the abdomen, so I'm not going to detail it, but you have to know in details about the deep fascia of the thigh. Deep fascia of the thigh is also called the deep fascia of the lower limb as such, but deep fascia of the thigh is also called fascia lata. L-A-T-A. Lata means extended. It's a very much extended fascia. That's why it is called fascia lata, and that is attached medially in the pubic arch. That is ischiopubic ramus and the ischial tuberosity, and anteriorly, it is attached from the anterosuperior spine inguinal ligament to the pubic tubercle. Laterally, it is attached to the, actually, it goes laterally to the iliac crest, and posteriorly, it attaches with the gluteal fascia and reaches the sacrum and coccyx. In this way, and inferiorly, it is attached to the bones of the knee region, that is the medial condyle, lateral condyle of the femur, and other areas. So it is making a sheath-like structure for this whole thigh, and also it goes downwards, but this part is called fascia lata. Fascia lata means extended. It's a very much extended one, and it makes a sleeve-like structure, very tightly placed sleeve-like structure, right? And this has got two modification. One is the iliotibial tract, and another is the saphenous opening. These two you have to study in details. I'm just giving a hint of this, that on the lateral side of the thigh, the deep fascia of the thigh is thickened to form a tract that is called iliotibial tract, which attaches to the patella downwards, and above it splits to accommodate two muscles. One is tensor fascial lata, another is the gluteus maximus. And in between them is a gap actually, and that is called the gluteal aponeurosis. It's right. So these tensor fascial lata and these gluteus maximus are covered by the splitting of the uh, iliotibial tract superiorly. And it is very important in maintenance of the position of the knee. We'll study it later. And there is another one. This is one modification of the deep fascia of the thigh. Another modification is saphenous opening that will be discussed in details by the teachers who would be discussing the. And if I have to, then I'll be discussing it in details, because saphenous opening requires a very much detailed discussion. Anyways, that is also another modification of the deep fascia of the thigh. Right. And so these deep fascia of the thigh is not only limited, the deep fascia is not only limited to the thigh region, rather it goes to the leg region and other regions. And there are other modifications of the thigh. This is very common question. What are the modifications of the deep fascia in the lower limb? One, you have got the iliotibial tract. Another, you have got the saphenous opening. And there's a common one you know, all know, that is the intermuscular septum. And other extensor reticula and flexure retinaculum, these are also the deep modifications of the deep fascia of the thigh, the deep fascia of the lower limb, right? So how many? iliotibial tract, saphenous opening, then the intermuscular septum, extensor retinaculum, and flexure retinaculum, right? And you have to study these things, extensor retinaculum and the flexure retinaculum in detail, and also the intermuscular septum and the saphenous opening and iliotibial tract. These are all the modifications of the deep fascia. Now, so we have just have given you the idea how these deep fascia encloses whole of the lower limb, and particularly in particular sites they have got the modifications. Now come to the lymphatic drainage. I'm just giving you the ideas of the lymphatic drainage. See, lymphatic drainage. And one thing you can see from this figure that the veins are very much regularly and very nicely distributed all over, not just the great saphenous vein, not just the small saphenous vein, rather they are forming network all over the thigh region, all over the actually the lower limb, all over the lower limb. So when we draw, we simplify these figures, but we must keep in mind that veins are everywhere, not only in the sites that are shown by the pictures in the simplified form. Okay, these are the superficial vein, these are the deep veins, and these are the communicating veins and perforating veins. Similar thing about the lymphatic drainage, that we always draw the lymphatic drainage in simplified form. We just draw the lymph nodes and we think then that's all. But lymph nodes, how will these lymph nodes get the lymph from? They will, where the lymph starts from. Can anyone tell me what is lymph? Can anyone tell me, please, what is lymph? Hello?
Yes, sir.
So what is lymph?
Lymph sir, fats থাকবে স্যার, এগুলো স্যার
বলেন। Everyone is free. It is open question. What is lymph?
স্যার ভেসেল মানে ভেন দিয়ে যেগুলো ড্রেন করতে পারে না, যেমন মেক্রোমোলি.
Sir, it is a fluid
The transient between plasma and
circulated
interstitial
through the
fluid.
lymphatic system.
So we are telling that it's a.
It is a
Transient
fluid which.
Okay, let me tell you. Let us make it very much clear. The lymph is nothing but the extracellular fluid, which has entered into the lymph vessels. Lymph is nothing but the extracellular fluid. Simply, it's the extracellular fluid, right? When it has entered into the lymphatic vessels, it becomes lymph. Is it clear?
Yes.
We know there are extracellular fluids, intracellular fluids, right? In our body, there are extracellular fluid, intracellular fluid. Is it clear? Of course, you know it from your physiology knowledge. You have extracellular compartment, intracellular compartment, distribution of these extracellular, intracellular in details you have studied. So I'm not going to discuss about that. But thing is that lymph is nothing. You just have an idea. Lymph is the extracellular fluid that has entered into the lymphatic vessels. Why it will enter into the lymphatic vessels? That you have told. In some places, the veins can't reach, and even they can reach, they can't drain the things that we need to drain. Particularly in some sites, the lymphatics has to perform very specific function like the GI tract. The lymphatic vessels carry the big chunk of big particles of the fat in the form of what? Lacteals. Right. So lymph not only performs the function that you have a common idea, we all have a common idea that from where the venous return is not possible, veins can reach and veins can't come out from these areas, these are drained by lymph. This is a very much generalized idea, very much simplified idea, because in some places there has to be lymph, no veins, because veins can't, say for example, I've given you the example of the GI tract. You have studied the GI tract histology, and you know the presence of lacteals in between in the core of the center of the villus, isn't it? Lacteals.
Sir.
What are the functions of the lacteals? Are they involved with sort of venous return type thing, or they are involved with the return of fatty particles, right?
Yes,
so so the lymph is not for only purpose to subserve or to act as an alternative of venous return, but it has got some specific functions. But one thing is for sure, that everywhere lymph starts from the tissue level, not from the heart. Artery starts from the heart and makes a capillary, and then returns to the
form vein.
right, then returns to the veins, heart through the veins. But lymph starts at the tissue level. Lymph starts where? At the tissue level, right? It must be made. Lymph starts from the tissue level, and then what happens? Then they reach the venous side through what? You must know these things clearly. Then what do? Where did they go? Either through the thoracic duct or the right lymphatic duct, they reach the venous side. Isn't it so?
Yes, sir.
Any confusion? Have you got any confusion regarding that? All the lymphs ultimately returns to veins. Is there any confusion of it regarding this?
No, sir.
Definitely, there should not be no confusion. Either through the right lymphatic duct or through the thoracic duct, they will return to the venous system, jugular veins, internal jugular veins. Then these will return to the heart. So there's no chance of confusing these things. Let me show it again here. I think that you are having some confusion regarding this. Say, for example, these are the lymphatic drainage. You can see it from here. This is the arteriole, then the capillaries, and these are the cells. Within the loops of the capillaries, the tissue cells are located. And what happens? This oxygen-rich blood leaves the oxygen to the cells and takes away the carbon dioxide produced by their metabolism of these cells. And thereby they become deoxygenated, and that returns, making a loop that is called post-capillary venules, then veins, and then finally reaches to the heart, right? This is the normal way of circulation. But you can see the lymphatics are starting here in the tissue level, the cellular level. And you see these lymphatics are where it is opening. It is in the cellular fluid. If I magnify it further, you can see it, that all the lymphatics are starting these in the blue. These blues are the extracellular fluid. Please go through the very nice. This is a picture from the Moors. And if you see this picture, you'll never ever forget about these things. If you don't follow these pictures and these figures, you will always have to memorize and forget. But if you see it for one time, it is a lifetime achievement, right? You can see all these lymphatics are starting in these blue areas, and these blues are, the extracellular fluid. So what I've told, that lymph is nothing but the extracellular fluid that has entered into the lymphatic vessels. These are the lymphatic vessels, small, these are the larger even. And so these extracellular fluid, when enters into these lymphatic vessels, lymphatic capillaries, they become lymph. And they has to pass through some lymph nodes. And lymphatic nodes, these are called lymph nodes, where you will study in details about the structure of the lymph nodes in the histology classes. I'm not going to detail it, but these are the afferents, and this is the single efferent, and these are the afferent, and this is a single efferent lymphatic vessels. And these passes through next set, until it reaches the venous system. How? Let's see it from this figure. And you have studied for abdomen, I have told you, there's a general rule that all the abdominal viscera has to pass through at least 3 sets of lymph nodes before it gets to the blood. And in case of lower limb, it's not like that. There are two groups of lymph nodes. One is superficial lymph nodes, and one is deep lymph nodes of the lower limb. And through them, they will pass. But before that, I'll be telling it later. But before that, you see how all the lymphatics are actually draining to the venous system. These are the limbs of the lower limb. These are the lymphatics of the abdomen. These are the lymphatics of the lymphatic. Lymphatics means the lymph vessels of the uh, head and neck region, and these are the lymphatics of the upper limb. And you can see all the lymphatics of the lower limb and abdomen and all the things are going through the thoracic duct to the junction of the left subclavian vein, and there they are actually draining into the venous system. Similarly, also the lymphatics from the left half of the head and neck region, and the left part from the left upper limb, all these, and left side of the chest, all these are going to the thoracic duct. And similarly, we know the drainage of the right lymphatic duct, that is from the right half of the head and neck, right upper limb, and right half of the chest above the diaphragm. These goes to the right lymphatic duct. They are also joining the right subclavian vein, and in this way they are actually draining into the venous system, not to the heart directly. So they are not directly starting from the heart and ending in the heart, to the heart. But blood circulation system starts from the heart and ends into the heart. That is one major difference. And that's why the blood is called circulatory system. Both are vascular. Blood is vascular as well as circular. But lymphatics is vascular but not circular. Why? Because both of these systems, the blood vascular system, why it is called? Because they pass through the vessels. Lymphatic system is also called vascular because they also pass through the vessels. But blood is also called circular because it starts even a single drop. Even if I follow or trace a single drop of blood, it will start from the left ventricle, and eventually after its completion of one single journey, it will again reach back to the left ventricle. So this is a complete circular journey. That's why it is also called circular. But lymphatic is the only vascular but not circular. You must remember these things. That means lymph starts from the tissue level and is the extracellular fluid that enters into the lymphatic vessels. I hope from now on you'll never ever make a mistake what is lymph. And for adding to this, we will add the concept that lymph does some specific functions in the specific part of the body, like as I've told you in the GI tract. But again, there are some areas where there is no lymphatic present. Why? That is also explainable. Why there is no lymphatic in the brain? Why there is no lymphatic around the alveoli of the lung? Can anyone explain? Forget about the brain, you have not yet studied. But why there is no lymphatic around the alveoli? Is there any lymphatic in the lymphatics in the lung? Is there any lymphatics in the lung?
No, sir.
Of course there are. Lymphatics are there, superficial lymphatics, deep lymphatics, lymphatic lymph vessels, superficial lymph vessels, deep lymph vessels of the lung. But they don't reach the alveolar level. Around the alveoli, there is no lymphatic. Why? There is lymphatic in the lung, but not around the alveoli. Why? You'll tell me in the next class why there is no lymphatic around the alveoli. Okay, let us go back to our original thing that I wanted to tell you. I was not actually thinking of telling you here. I want to get back to the cutaneous supply, lymphatic drainage of the lower limb, right? So lymphatic drainage of the lower limb, as you can see, it has been divided into two groups. One is upper, one is upper horizontal group and is lower vertical group. Right, upper horizontal group is located where? এটা তোমরা দেখেছো তোমরা? Have you seen it? Upper horizontal
Inguinal
group?
region, sir.
Around the inguinal region, inguinal ligament. This one is the called upper horizontal group of lymph nodes. Upper horizontal group of lymph nodes, and this one along the saphenous vein, long saphenous vein, there are two groups. These are called lower vertical sets, and this is horizontal. And again, this upper horizontal set of lymph nodes are divided into lateral one and medial one, and the lower horizontal and lower vertical group is again divided lateral, medial, and lateral ones, lateral groups. And for easy understanding, you can see, if we generalize, very simplify the things, that these upper horizontal groups, and let me show you one thing, very simple one. This is actually the details of the lymphatic drainage. So the upper lateral superficial group drains from the skin of the abdominal wall below the umbilicus and upper superficial inguinal lymph nodes. These drain to the upper lateral superficial group and partly to the medial one. But the some lymphatics from this uterus also passes through the inguinal ligament to the inguinal lymph nodes. It's an extra kotha. This is an extra information from the uterus and from the external genitalia. There is a difference of the drainage of the glans, penis, and clitoris, and rest of the external genitalia. দেখো আমরা যদি সিম্পলিফাই করি তাহলে হচ্ছে upper lateral groupটা mainly not only from the upper part of the limb, lower limb, also from the abdominal wall around it below the umbilicus is draining into the upper superficial inguinal lymph nodes altogether, both the lateral and medial ones, right? But the upper medial one, superficial one, gets supply from especially the external genitalia and lower part of the vagina into upper medial superficial lymph nodes. But the glans penis and glans clitoris are not drained into the upper medial. Rather, they go to the deep medial inguinal node that is called lymph node of Cloquet in the right. These are the deep inguinal lymph nodes. They go to the glans clitoris and penis goes to the deep inguinal lymph nodes, medial one. So you can say, if we simplify that the upper lateral and upper medial lymph nodes get supply from the around the skin of the abdomen below the umbilicus, and the superficial, this one is the upper lateral one and also medial one. Particularly the medial one gets supply for the drains the external genitalia, the lower part of the vagina also drains into this region, except the glans penis and clitoris, which drains to the deep inguinal lymph nodes. But this lower superficial one is T-shaped. This is called T-shaped, the upper superficial and lower superficial, and this one is the deep inguinal lymph node. Okay, so this T-shaped arrangement of the superficial inguinal lymph nodes, this upper is again divided into lateral and medial, and the lower one is the superficial. And this lower superficial one receives from most of the lower limb, except some parts of the back of the leg. So you can now understand, and all these superficial lymph nodes, all these lymph nodes from the inguinal region passes to the external iliac, that is from the both the deep and superficial. All these are actually passing to the iliac lymph nodes and partly to the aortic lymph nodes. That has not been shown here. So you can understand the lymphatics of the lower lymph nodes of the lower limb are located in the T-shaped manner, the superficial ones, the upper horizontal one in the upper lateral group, upper medial group, and the lower superficial group in the vertical one. And these are the deep nodes. And deep nodes get supply from the lymphatics of the trine directly into the deep lymphatics of the thigh, which actually follow the arteries. All these deep lymphatics follow the arteries, and these lymphatics directly drain into the deep inguinal lymph nodes. Also the popliteal one And the deep lymphatics of the foot and leg and superficial lymphatics of the back of the leg reach the popliteal nodes and then to the deep inguinal nodes. You can understand. So from the deep inguinal nodes, it goes to the external iliac nodes and aortic lymph nodes. All, both the superficial and deep. And what about the superficial ones? The superficial veins, lymphatics from the most of the lower limb goes to the lower superficial and then to the deep and then to the external iliac and aortic lymph nodes eventually. But the skin from the abdominal wall below the umbilicus goes to the upper ones. Upper ones means both the lateral and medial. And medial superficial one receives the lymphatic from the external genitalia and lower part of the anal canal and the lower part of the vagina, except there's one glans penis and clitoris, which goes directly to the deep inguinal lymph nodes. So in short, this is about the lymphatic drainage of the lower limb. Is it clear? Any question? Any question? Hello? এগুলা কটা বাজে?
11:22
আমাদের টাইম কি শেষ?
না স্যার 11:30 পর্যন্ত।
11:30। তাহলে আমরা এটা তো আমরা বললাম। এটা নিয়ে আর কোনো প্রশ্ন আছে?
না স্যার।
এগুলো কিন্তু আসবে এবং এই ছবিটা আঁকতে পারলে একদম ইজিলি তোমরা সবকিছু দিতে পারবে। এটা নেওয়া আছে ইন্টারভিউসিং থেকে। এটা দেখো খুব সহজ করে দেওয়া আছে এবং খুব সুন্দর করে সমস্ত পয়েন্ট, অল দ্য পয়েন্টস আর হিয়ার। এখন আসো কিউটেনিয়াস সাপ্লাই। এখানে আমরা যেটা বলেছিলাম কিউটেনিয়াস সাপ্লাই বলতে আমরা কি বুঝি আর ডার্মাটোম বলতে কি বুঝি, তোমাদের এটা জানা আছে? কিউটেনিয়াস সাপ্লাই আর ডার্মাটোম মনে আছে? What is cutaneous supply and what is dermatome? What is the difference between cutaneous supply and dermatome?
So cutaneous supply comes from one single nerve which can have multiple spinal segment origin, but dermatome is a supply which comes from a single spinal segment which can pass through different nerve endings.
সব বলে পেছ লাগাচ্ছ কেন? সবকিছু তো ঠিক ছিল কিন্তু লাস্টের প্রথম লাইনটা খারাপ ভুল বলেছো আর লাস্টের লাইন
মানে স্যার ডার্মাটোমটা হচ্ছে স্যার একটাই স্পাইনাল সেগমেন্ট থেকে আসবে স্যার, কিন্তু এটা মাল্টিপল নার্ভ থেকে বের হতে পারে স্যার।
ডার্মাটোমটা একই সেগমেন্ট থেকে আসবে, হ্যাঁ, দ্যাট ইজ দ্য মেইন পয়েন্ট। হ্যাঁ, আর কিউটেনিয়াস সাপ্লাই
স্যার একটা নার্ভ থেকে আসবে কিন্তু স্যার এটা মাল্টিপল স্পাইনাল সেগমেন্ট থেকে স্যার অরিজিন থাকতে পারে,
হতে পারে অথবা সিঙ্গেল সেগমেন্ট থেকে হতে পারে, সেটা ডিপেন্ড করবে যে ইট ক্যান কাম ফ্রম আ সিঙ্গেল সেগমেন্ট অর মাল্টিপল সেগমেন্টস বাট পাসেস থ্রু এ সিঙ্গেল নার্ভ। হ্যাঁ, স্পাইনাল নার্ভ না, সিঙ্গেল নার্ভ। স্পাইনাল নার্ভ আর নার্ভের মধ্যে পার্থক্য, there is a difference between spinal nerve and nerve. Say for example, এই যে anterocutaneous nerve of the femoral branch, anterocutaneous branch of the femoral nerve, অথবা lateral cutaneous nerve of the thigh. These are named nerves, though they are cutaneous nerves, but these are named nerves, but they are not spinal nerves, right? এটা কিন্তু তুমি একটু আগে ভুল বলেছিলে, এটা single spinal nerve, not the single spinal nerve. Actually, it is supplied by a single nerve, which may get 8 fibers from a single segment or multiple spinal segment. A dermatome is the area of supply from a single segment of the spinal cord or by a pair of spinal nerve. দুইটা কথা, either you say a single segment of spinal cord or you say a pair of spinal nerves. এটা কিন্তু একদম ক্লিয়ার করে বলতে হবে। এবং এগুলা আমরা দেখতে পাচ্ছি যে দেখো এগুলা বোঝাই যাচ্ছে ল্যাটারাল কিউটেনিয়াস ব্রাঞ্চ, এগুলা ব্রাঞ্চিং গুলো তোমরা যত বড় করে দেখাবো তত আরো ভালো বুঝতে পারবে যে এগুলো তো আছেই, এগুলো বইতে আছে, এগুলো জাস্ট পড়তে হয়। এবং why do we need to have the cutaneous supply to know? আমাদের এগুলো জানতে হবে কেন? cutaneous supply, dermatome, why do we need to know? এগুলো প্র্যাকটিস করতে, বিশেষ করে যে ডার্মাটোমটা আঁকা প্র্যাকটিস করতেই হবে খুব ভালোভাবে। কেন বলো তো, এগুলো জানতে হয় কেন? কেউ কি আছো স্ক্রিন আছো নাকি নাই? সব নাই হয়ে আছি স্যার, সংখ্যা কম কেন?
স্যার এফার্ট পেইনের জন্য বা সার্জারির সময় স্যার আমাদের প্রত্যেকটা ডার্মাটোমকে স্যার ডিমার্কেট করে রাখা হয় যে কোনো একটা জায়গায় সার্জারি করার জন্য সেখানে স্যার অ্যানেস্থেসিয়া অ্যাপ্লাই করার জন্য আমার কোন স্পাইনাল সেগমেন্টে অ্যানেস্থেসিয়া অ্যাপ্লাই করতে হবে
রাইট, এটা একটা ইম্পর্টেন্ট, কিন্তু সবসময় আমরা সার্জারি করি না, কিন্তু তারপরে আমাদের ডার্মাটোমি ইম্পর্টেন্ট।
রেফার্ড পেইন স্যার,
পেইন বোঝার জন্য, পেইন না, রেফার্ড পেইন তো একটা সব জায়গাতে ইটস নট অ্যাপ্লিকেবল ফর অল দ্য প্লেসেস, বাট we have to locate the involvement of the spinal cord, which segment of the spinal cord has been involved. সেটা আমরা বোঝার জন্য we try to identify the areas where there is no anesthesia, there is no sensation, right? Say for example, if I find that this area of the thigh is having no sensation, then I'll get the idea that actually it is related to the lumbar 1 segment of the spinal cord. In this way, if this area is not having the sensation, then I'll get the idea that it is related to the lumbar 2. In this area, sacral 1. So these finding out, I always tell you, neurology is a very interesting subject. You can identify most of the diseases with a single hammer, clinical hammer, and a pin. That's all. You can identify most of the neurological diseases. Even you don't need to have the CT scan MRI in most of the cases, because this is a mathematical one. You can identify all the complicated diseases of neurology with these two instruments. One is hammer to identify the jerks, and to a pin to see the dermatomes which are anesthetized and which has got the sensation and which don't have. That's all. But for confirmation, actually we go for the MRI or CT scan or whatever. But problem is that the treatment of most of these neurological diseases are not yet available. So you can identify the disease, but you can't give the remedy in most of the cases. That is the problem. But there's some very interesting things are there. When you study the neurology, you'll see that everything is very much definite. It's not a vague pain or vague identification or diagnosis. It's a very pinpoint diagnosis you can make from your knowledge. If you're a good clinician, if you have the knowledge and you can elicit the history very nicely from the patient, you can identify the disease very nicely, very precisely. But in most of the cases, we can't offer the treatment like Alzheimer's disease or like these things, dementia. We can't give the proper treatment to the patient because it is not yet available, but we can identify the disease properly. Okay, that is the importance to know the exact location. And Din Mohammed sir, you have heard the name of Professor Din Mohammed sir, legendary neurologist who has single-handedly changed the scenario of the fate of the neurological patients. In earlier days, the neurological patients, the patients of stroke, were supposed to be in one corner of the medicine unit, and they would have died untreated, and less treated bed sores will be there and they would die one day. That was the fate of the neurological patients before Din Mohammed sir took over. But he has developed the individual neurology department, and now there is a huge institution, National Institute of Neurosciences, where both the neurosurgery and neuromedicine is going on hand on hand, right? So he is the pioneer, and I had the chance to have a class of him when I was a student of neurology way back in 2007-8. And he told one thing, that please try to remember as along the daily life. He told me that yes, we sit on S4, S3, L2, because that is the buttock region we sit on. We put our hands in the L1, L2 region when we put it in the pocket. We do ojus, and we use these dermatomes. When we lie down, we use these dermatomes. When we walk, we actually use these S1 and L5 dermatomes. So this is how he remembers the things. And he told me that please make a rule for yourself. how we remember these things, because there is a definite rule. It's not haphazard. L1, then L2, then L3, then L4, then L5, then S1, then S2 is turning to the medial, then S2. So you can understand there is not, then is going back, and S2 is continuing on the S3, S4. So S3 is, S4 is again returning to the front, and this is forming the S2, S3, and this is actually a very located in very definite pattern, right? You can see. So if you can remember one thing, that L1 starting from L1, L2, L3, L4 is long, L5 is long, reaching to the front of the most of the part of the, this is the dorsum of the foot and the plantar, and then you can see, and S1 is on the lateral side, and S2 is partially on the medial side, then it is going back and forming the most of the part of the backside, and then it joining this S3, S4. So you have to practice it many times and remember it as your part of life. The Momo sir rightly said that we sit on L2, S2, S3, S4, particularly S3, S4. He rightly said, mentioned it. And we put our hands in the L1 and L2 because the pocket region is here. Most of our pockets are here. So you can understand we walk on S1, L5. And this is how you should remember. We should remember that what are the dermatomes, and these are the very important information for your neurological practice, clinical practice. And two things are there. One is axial lines, and you know what is axial line? Axial line, you know it? Axial line. What is axial line? You have studied it in the super extremity. Please, anyone? এগুলো পড়তে হবে, কিন্তু এগুলো ভুলে চলবে না। শোনো, if you want to easily grasp the inferior extremity, go through the super extremity for a single time, then you come to the inferior extremity. It will help you to recall and compare these two systems, and it will be very much beneficial. So axial lines, I'm told you have studied it, is the where the two discontinuous dermatomes meet. Axial lines are the lines where the two discontinuous dermatomes meet. See for example, for here, this L1, L2 and L3 is continuous. L3 and L4 is continuous. L4 and L5 is continuous. That's why there is no axial line here. But you can see here, in this side, lateral side is S2, and medial side it is L3. No continuation in between these two. Similarly, this is S2 here, this is L4 here. So no continuation between these two. So axial line is the line where two discontinuous dermatomes meet. Right? So you must know these things. So with these, we have discussed about the lymphatic drainage, the venous drainage, the intermuscular septum, the muscular deep fascia of the thigh, and the modifications of the deep fascia of the thigh, as well as modification of the whole lower limb. Then we have discussed about the lymphatics, lymph in details, and little one of the dermatomes and cutaneous supply, varicose vein. What we couldn't do is the intermuscular septum. We have discussed about it. But what we couldn't do, but I had a desire, intention to discuss the motor innervation of the lower limb. In the next class, we'll be discussing about that. Okay. For today, thank you. Any question, please?
No, sir.
One thing I'll request always that please go through these nice books. If you don't have, I'll be sending these, the copy of a PDF copy of these, Moore's and other books. You see, if you see these figures, it will be a lifelong containment. I hope. If you see, as I've shown you the lymphatics, I think you'll never forget that lymph starts from the extracellular level, and this is the extracellular fluid. In this way, these figures tells many information, gives much more information than the simple texts. And I hope that you will use your idle time, or you are getting the extra time when you are in the home, because COVID has given us some opportunities as well. Some problems as well as some opportunities. You are now a student of the world. All the world teachers, world famous teachers are your teachers, right? You can go to the internet, you can go to every possible and available resources, and you can use them. And when you can't understand anything, please tell us. We will try also from our side. But you have all the time, the the very much idle time, very you can utilize it. I think it is a very lifetime chance that you can modify your life on your own. Though there is a challenge, but you can do it. I hope you are the DMC students, so please make the best use of your time. Okay, don't just spoil it. See these figures, go through many books, and you'll be having a very easy understanding and effective understanding of anatomy. Thank you. Thank you very much.
Thank you, sir. Assalamu alaikum.
Please feel free to tell me if you need these things or already you have these.
That this book, sir.
You need these books. Okay, I'll be giving it to one of you and he will be sharing it to others. Okay, I'll be giving it to Mushfiq because I have his email address. I'll be sending it to him. Okay. Okay.
Assalamu alaikum.
Salam.